meeting is being recorded.
Hi, good morning, Jessica.
Good morning, Teresa.
How are you today?
I'm okay. I'm okay. Good morning. We are a stroke certified hospital. Today I have Teresa Flom, who is the stroke program manager. We will talk about how to initiate and follow up stroke measures. For the purpose of intellectual property protection, this video can be used only one time in April year 2024 for 绵阳市中心医院护理部. Now I have it, this time I give it to Teresa.
Hi, good morning, everyone. My name is Teresa Laflamme. Thank you so much, Jessica. And you can see me good on the screen? Okay, good. Well, I am the manager of our stroke program here at our primary stroke hospital. And we're just going to go over some of the daily things that we do here to run the program. And we'll go over with you the learning objectives for today, which is an introduction to stroke. We can review the pathology of stroke. We're going to go over our AHA, which is our American Heart Association, and our ASA, which is our American Stroke Association, stroke measures. And then we can jump into the Stroke Core Measure Initiative and how we make sure that the measures are followed in our hospital. We have a special initiative that we check patients for swallow screening for safe swallowing before they take any intake at all, which means any oral intake for diet or for fluids, or also any oral medications. And that tool that we use is called the Yale Swallow Screen. Then we have some tips for you about performing the Yale Swallow Screen. And then we'll end it by going into some nursing focuses that we have here, where we focus directly on stroke. So we'll start with what is a stroke. So as we all know, a stroke can be devastating, and it can cause the patient to have deficits when there is not enough blood flow to the brain. So our definition that we share with the staff here is that a stroke occurs when the blood flow to the brain is interrupted by a blocked or a burst blood vessel. So there are two different mechanisms that occur there. One, the vessel could be blocked and not allow the oxygen to go through. The other, it can be burst and the blood vessel can break. Either way, whether it's a blocked stroke, which is basically ischemic, or a burst stroke, which is a hemorrhagic, we are always concerned about getting treatment to the patient quickly, because time is brain. Every single minute counts. And if you look at the slide and you see how many brain cells are lost during a stroke, we can break it down into a few different categories. For each stroke that occurs, 1.2 billion neurons or 1.2 billion brain cells are lost. When we lose that amount of neurons, the amount of years that our brain ages is we add 36 years to the aging of the brain, which means we just lost 36 years over our life expectancy. So this is a problem because we might live through a stroke, which would be called mortality, but how do we live? It could be that we don't live at the top level of our best self. We don't live at our optimal level of functioning. So you add 36 years to your life expectancy and you're already more disabled than you should be because of losing all of those brain cells. And then if we break it down even further and we say, well, how fast can we go to get stroke treatment to a patient? And we do it by the hour. 120 million brain cells are lost every hour. And that equals approximately 3.6 years of aging on the brain. So what we try to do here is, because we say every minute counts, and we want to make sure if we can find a new technique or a new process, that if it even just shaves 1 minute, that is helpful. Because sometimes staff members will say, well, it's only 1 minute. What does it matter? It does matter in stroke, because every minute, every single minute during a stroke, 1.9 million neurons die. So that's 1.9 million brain cells that are lost, and that is going to age us by another 3.1 weeks on our life expectancy. And the studies and the data shows that you could even break it down by second. But what we use here is we talk about how many brain cells are dying per minute to help expedite and give a focus, a sense of urgency to every single stroke or code stroke that we call, to save the brain, because time is brain. And you can see here over to the right, this picture where it says time is brain. And we're going to look at what happens over the hours and over the days. So this top picture here, where you can see it's like a small little brown area in the brain, and within it is a black dot. That is showing you a picture of what's happening in the side of the brain as the brain tissue dies. So the black area is where the stroke has already occurred. That is where the dead tissue is. That's called the core. And the core of the brain is death of tissue. That's never coming back. So that little black spot is already permanent damage. But what's happening in that picture is the area around it, which is like the lighter brown, is the area that's in danger. So that is called what we call penumbra, which is penumbra, penumbra, and it's salvageable. So that's the area that can be saved. What's happening there is the oxygen is not getting to that whole area. Some of it died, dead tissue, already done, but the rest of it is in the process of dying. It's not dead yet, but it's being choked because the oxygen can't get there. So it's literally being choked out. And if we don't move quickly, that little tiny black area is going to get bigger and bigger because more brain tissue is going to die. So if you move along and you say, let's add an hour, let's add 60 minutes and see what the brain looks like. So by that point, you could have lost 120 million neurons. But look at what happens in the picture. That little tiny black dot now turned into a big area of dead tissue. So now we have the core of the stroke is growing and it got bigger. And the brown, the light brown on the outside got smaller. So now we have less tissue that we can save. A very small amount of salvageable tissue, a very small penumbra. So already we're getting to the area where it may be too late to do something. And if the patient came in at 24 hours the next day, look what happens the next day or the day after that. That area that had even a little bit of brown is gone. So this means the stroke has completed itself. The whole area is already dead. So that area of the brain, that will never come back. It's dead forever. It's the same as if we kind of associate that with a heart attack. The piece of the heart that becomes ischemic and then dies, that piece in the heart never comes back. So there's always that scar tissue in the heart, and the rest of the heart has to take over to help the heart beat properly. And the same thing is occurring in the brain. So the rest of the brain cells, the rest of the neurons are going to have to step up to the plate, and they're going to have to step up and take over some of this function that got lost, because that area is now a completed stroke and it's too late. There's nothing more we can do about it, but treat the patient medically. So if we say that that matters in both a hemorrhagic stroke or a bleeding stroke, the core that we were talking about, that last picture, refers more to an ischemic stroke because of a blockage. So whenever there is a blockage in the brain, the cause of the blockage could be a variety of things. It could be the plaque building up on the inside of the artery so it doesn't get through, or it could be a thrombus where there's a clot stuck there. But either way, something is blocking the blood from flowing. So inside our blood, if we have hemoglobin, we know hemoglobin carries oxygen on its back. And if that blood is trying to flow through and it can't get through because it runs into a wall or some kind of blockage, that means the oxygen can't get through. Therefore, everything on the other side of that blockage is going to die. And that's death of the cell. And that's the blockage for the ischemic stroke. The same outcome occurs with a hemorrhagic stroke, but it occurs with a different mechanism. So in the top picture here, we see ischemic stroke, and we can see the area highlighted where it stopped with the red blood flow, and everything beyond it, there's no flow. So if we magnify that to see what happens, you can see inside the intima of the artery of the vessel, all of this white plaque. And before the plaque even met from one side to the other side to close, there was another clot or thrombus that broke through from somewhere else, and it couldn't get through that narrow little pathway, so it got stuck. So there's the problem there. There's no blood flow on the other side, blockage, ischemic stroke. And we say the bleeding stroke is this one, right? It's caused by a burst or a leaking blood vessel in the brain. And it has the same effect because it's still lack of oxygen to an area. But how it happened is why it's different. So if we look at the vessel here, it got weak in one spot, like the wall is weakened, maybe from high blood pressure, too much pressure on the vessel. It could be an AVM, which is an arterial venous malformation. And that could be weakening it because the artery and the vein are meeting with each other. They're malformed and it can burst. It could be a small aneurysm that bursts. So there's a lot of different reasons. But if the blood vessel weakens or gets diseased, that blood vessel is going to rupture. Now you have blood leaking out of the vessel. The brain doesn't like that. The brain wants that blood to stay inside the vessel where it's nice and clean. But when it comes out, and it leaks into the brain cells now become sticky with that blood, and we decrease the oxygen saturation of the brain cells that are good. So either way, you're not getting oxygen to the brain. It's just for two different reasons. That's why we break it down into basically two types of strokes. We have the ischemic stroke and we have the hemorrhagic stroke. For us in the United States, when we look at our data, 85% of all strokes are ischemic strokes, which are the blockage ones. So that's the ones we see mostly. The hemorrhagic strokes occur probably 15% of the time. So we do see them, but we see a lot less of those patients or those types of strokes. Then there's a third type of mechanism that we have to look at because we see this a lot. It is known sometimes as the mini stroke. It's not really labeled correctly because when you say mini stroke, someone thinks they had a stroke, but it's almost the opposite. It's the mechanism and it's the symptoms of what a stroke looks like and how it occurs, but there's no permanent damage. So in an ischemic stroke and a hemorrhagic stroke, there's damage done to the brain. The TIA / its little nickname, mini stroke, is only transient. So TIA stands for transient ischemic attack. And what happens there is the brain experiences a temporary lack of blood flow. So it might be just for a minute or 5 minutes. It could be anywhere up to 12 hours a TIA, but usually for TIAs, trans ischemic attack, the symptoms resolve within 1 hour. So the good news about that is because it resolves, that means there's no damage to the brain. The bad news about that is sometimes our patients are very happy that they didn't have permanent damage and they think they can just go home and continue to carry on in their life the way they did before because they feel like, good, nothing bad happened. But it's not true. because a TIA is a warning. It's a warning that something is happening. You don't have a TIA for no reason. The TIA is caused by something. So somewhere in the brain, there's an unhealthy artery, or there's high blood pressure that's squeezing on the vessel. The unhealthy artery could have plaque in it from high cholesterol, from diabetes. So there's something underlying it. So we always teach our patients with a TIA, you stay overnight, one night under observation, and we run a bunch of tests because we want to get to the bottom of the story. What happened? Why did you experience a TIA? Why did you have this mini stroke situation? If we don't fix that, a large majority of the patients, sometimes even up to 50% of the patients in the next 30 days, come back and actually have a stroke because we never dealt with the underlying cause. And the main data point that we teach them and we explain to them is that 80%, like a large percentage of strokes, 80% of all strokes can be avoided, prevented, if you find out what your risk factors are and you address them. Is it high cholesterol? Let's go on medication, fix the diet, exercise. Is it diabetes? Go on medication, exercise, fix the diet, get to the bottom of the cause. We have to look at everything and be like detectives to try to figure out what the cause is for that patient, because 80% of all strokes can be avoided if we find out what the risk factor is, that exact risk factor of that patient, and we address it or try to fix it. If we don't fix it, if we don't find out what it is, that means a large percent of those patients will go on to have a stroke. So it's not perfect. Sometimes, it's hard to fight what the body is doing. So that means 20% of the time, even when we're trying to address it, someone may still have a stroke in the next 3 months. But for this, we know that by education and treatment and identification of what's happening, 80% of all strokes can be avoided. So we really do try very, very hard to identify the underlying cause and educate on that. So while they're here, because we are trying to make sure that they get the best care, and we always use evidence-based care, it's not something we just made up here. So we follow the experts. And the experts for us are the American Heart Association and the American Stroke Association. And they came up with scientific study and doing many, many different evidence-based studies on patients. They found the numbers that work the best to save the most amount of brain cells. So you can't always do everything at once, all in 1 minute. It takes time to safely figure these things out and move forward, but we have to move as quick as possible. So to stop an ischemic stroke, we have medication that can be given in a certain time frame. And that thrombolytic administration involves a few different kind of drugs, or fibrinolytics. Some of their names are Alteplase or Tenecteplase. And we have the goal aligned with the American Heart and American Stroke Association. They have recommended to us that we should make sure that we administer this medication, the thrombolytic med, within 45 minutes from the time the patient arrives in the hospital. So what we do is we call that door to needle, or door to medication. So if the patient were to arrive at our facility at 12 noon, that means by 12:45, we should have evaluated the patient, had the proper testing done, and administered the med. So our 45-minute goal is very quick in from when the patient arrives. When we're allowed to give the medication is up to like 4 hours, 4.5 hours from when the symptoms began. So if the patient woke up at 8 o'clock in the morning and they were perfectly fine, they had breakfast, they were making their coffee, they walked across the kitchen floor, and all of a sudden out of nowhere, their right hand got weak, and they drop the coffee cup, and that's at 8:15. That means we know exactly what time their symptoms started. So at 8:15, we start our clock. We have 2 clocks going at the same time. And the clocks are usually, we just have them in our brain thinking about it, but at some facilities, some hospitals, they actually have a clock timer that they can hit to time everything. So if the patient has come in to our facility in less than 4.5 hours from when those symptoms started, that means they're a candidate. That means they're eligible to get this medication. If they came in and they said their symptoms started 6 hours ago, anything greater than 4.5, they're already not a candidate because it's too late. They are not going to be able to get that. But then the second clock is now that they're here in our care and we have them in our facility and we evaluate them, we have clock number 2, which says, now you better get it in 45 minutes. Why wouldn't we give it in 60 minutes? Well, we'd rather give it in 45 if we can, because we just said before, every minute counts. Every minute, if 1.9, let's round up. If every minute 2 million neurons die, that means in 5 minutes, we just lost 10 million neurons. So we don't want to waste 15 minutes. Why shouldn't we try for our goal to be 45 minutes? Get it in as fast as possible, as safely as we can. Once we do the evaluation, we check labs, and we do our CAT scan of our head to check imaging. Once we do all those things, we have all of that to do, speak to the patient, and get that drug in. So our goal for that is always 45 minutes. Another goal we have is that when we make sure we're speaking to the patient and we're doing education, we check their swallow screen before you give any medications to make sure they can safely swallow, because aspiration pneumonia is a complication of stroke. And we want to always make our goal for that 100% of the time. Every patient needs to be educated. Every patient needs to be screened for swallowing. At the same time, we are also tracking times for our physicians or our provider. And we want to make sure from the time the patient comes in the door, the physician is called over immediately to see patients that have stroke symptoms. So we have less than 10 minutes for that goal. If the patient is not going to stay at our facility and we have to transfer them out to a higher level of care, those people have to be out the door in less than 2 hours. So you can see with all of this timing, we have to move pretty quick because we're timing ourselves on our goals. And then we have to get the patient over to CAT scan. So that means if we get them to CAT scan, we can get the imaging and the picture really, really fast. And we can see what's happening in the brain, and we want to do that in less than 20 minutes. Some hospitals like us, a primary stroke center, we don't always have a neurologist available every single minute all the time that they're here in the hospital. So what we do is we use an outside service, and that's the teleneurologist. So when we get them on the screen, we need them to be on the screen. We have a device downstairs, and it's audio and visual. That means the doc can see our patient and hear our patient can see and hear them. So they have a one-to-one evaluation with the screen. And we need them to be on that screen within 20 minutes because we're timing ourselves. So we have to quickly get the evaluation done by a neurologist so he can recommend the drug, the thrombolytic administration, which we want to give in 45. So if in 20 minutes he comes on, he talks to the patient, evaluates them, and it takes him another 20 to do his evaluation, look how tight we are. We now only have 5 minutes to give this drug. And then if we go on with our other measures, once the patient is admitted to the hospital after this, whether they get that thrombolytic agent or not, all stroke patients, we follow the guidelines on all stroke patients, whether they're a hemorrhagic stroke, an ischemic stroke patient, a patient who received a thrombolytic, a patient who didn't get a thrombolytic, and our TIA patients. We want to make sure they always get the best care. and that care is always evidence-based. It's proven to work the best. And if we do these measures, that means we are providing our patients with the best possible care to give them the best possible outcome so they can hopefully return to their prior level of function. So it's all about getting them back to where they were before. If they're working, we want to get them back to their place of employment. If they were driving, we want them to be able to drive again. If they were teaching, we want them to teach again. If they were a violin player, we want them to play the violin again. So how do we get them there? So when they come in, we want to make sure that they don't get any clots in their legs, because if they're already making clots in their brain, they might be in a position where they are overcoagulating and making different clots in different body parts. So for VTE prophylaxis, for our venous thrombus embolism prophylaxis, we're looking to prevent a DVT in the legs, and we're looking to prevent pulmonary embolus. And how are we going to do that? We have two different ways of doing that. It can be a mechanical intervention. And for mechanical, that means we would put our compression boots on, not just compression stockings, but we put on the anti-embolism boots. They're intermittent pneumatic compressions. So we attach that to a machine, and that will pump up and down intermittently, on and off, to prevent it, which gives it more of a massage effect, as opposed to putting on the elastic stockings, which are on all the time. So the elastic stockings don't work for us in the stroke world for this VTE prophylaxis. Only the pneumatic compression device, or the, we call them the boots, the ICD boots, the intermittent compression device, inflatable boot that will be on them 24 hours, unless for some reason we got them out of bed to ambulate them. But when they're back in bed, we put those boots on, and they go from the knee all the way down to the ankle. It's not a full leg, it's the lower leg, to help massage it and prevent stagnation of the blood, so that they are not clotting. But sometimes with patients, that might not even be enough. So we evaluate them for pharmacological VTE prophylaxis. And what do we use for that? We would use any of our anticoagulants like heparin sub-Q or Lovenox sub-Q. Those are our two major pharmacologic prophylaxis treatments that we use, or medications. The only exception to the rule is if the patient came in because they had atrial fibrillation and they were already on like maybe Coumadin or one of our newer oral anticoagulants like Eliquis. Those are anticoagulants, and we would say, okay, that should give them enough coverage. You don't have to do the heparin or the Lovenox. But we don't really start with that. We don't give people warfarin for this purpose, but it can help them. So for a patient that did not have any anticoagulation at home, for them, we would start heparin or Lovenox sub-Q. That would suffice our our pharmacologic prophylaxis. And then for the VTE, that would suffice if we were giving mechanical prophylaxis. So the boots are more mechanical, and the medications would be considered pharmacologic. It has to be one or the other, and that has to occur in the first 24 hours because we don't want those clots to occur. So that's another timed measure. Anticoagulation therapy on its own is required by our stroke core measures for all patients who have a history of AFib or atrial flutter. So atrial fibrillation, atrial flutter patients we have to follow the anticoagulation therapy measure, which means those patients have to be on one of the medications for that, like the warfarin or the Eliquis or even a heparin drip. They have to be on that within the first 24 hours and either continue with that or maybe bridge to some other form of anticoagulation. That is documentation that would occur, that a physician order would be placed, and the nurse has to follow through with that within the first 24 hours. If for some reason that can't be done, the only way we get out of this measure is if the physician would write and document in the note the patient is not safe to have anticoagulation therapy because they had a bleed in their brain, or because they have GI bleeding, or because they had a recent trauma. Without a reason, something needs to be ordered. If there's not an order, then there needs to be a reason. So the physician or the provider would have to say, not safe to order anticoagulation for this patient, even though they have a known history of atrial fibrillation, because they have a brain bleed, because they're at a high risk for fall. They're 95 years old. It's not safe for them to be on it. So they have to document why this is contraindicated. If they don't write a reason why, it needs to be done. If it's not done, you fail the measure. So that means we didn't follow the best practice. The next thing is an antithrombotic. It's the same exact theory. It has to be started in the first 24 hours. And under antithrombotic therapy, we have our antithrombotics and our antiplatelets. Examples of that would be our aspirin and our Plavix. They have to be started in the first 24 hours. If they're not, the doctor has to write a contraindication. Then we go to our highest level of anticoagulation. That's our thrombolytic therapy. And that's what we talked about before. We have to get that in 45 minutes. And that's our Alteplase or our Tenecteplase. But if the patient is not a candidate for thrombolytic therapy, the physician or provider must document why. So either they are a candidate and we're going to get that medication into them, or they're not. And they have to say the reason why. Our number one reason is the patient cannot receive thrombolytic therapy because they did not arrive to the hospital in time. So in other words, they were outside the window of treatment, which is that 4.5 hour window. So if they get here in 6 hours or they get here in 24 hours, the physician will write, it was too late for the treatment because they were outside the window of time. If they're less than that, we should be giving it, unless there's some other exception to the rule, like the patient refused, or the patient's blood pressure was too high and it was not safe to give it. But those are their only two choices. They either give the medication or they write the reason why they didn't. So those first few measures that have to be met need to be either met or a documented contraindication. Then we move on to more measures that are a little bit, I guess, more focused or assigned to either nursing or rehab therapy. So for stroke education, this would be the nurse is going to educate the patient on what type of stroke they had and what their risk factors are. We need to customize this because we make it specific to each and every patient. We say this patient has diabetes and high cholesterol. I'm going to educate them on what that means and what can be done about it. This next patient, their risk factor is that they have atrial fibrillation. We educate them on that. So it depends on what the risk factor is as to what we're educating. So it's very specific to each patient. It's not just general education. It's customized, specific stroke patient education to that specific patient. Then assess for rehab. We call our rehab team in. Part of our rehab team is PT, OT, so physical therapy, occupational therapy, and then we also have our speech therapy. So they will evaluate them, see where they're at, and make sure that they are assessed. What is their functional status and what kind of treatment do they need? Can they go to an outpatient? Can they just be rehabbed at home? Do they not need any rehab at all because they have recovered? Or the last situation is the patient has such a low functioning level, they're not safe to go home or do any kind of outpatient rehab. Then they're recommended to go an inpatient acute rehab where they will be in therapy at least 3 hours a day. So those people really need a lot of help to recover from their stroke. And then it would be time for discharge. And for discharge, we have to make sure the patient goes home with an antithrombotic, like either an aspirin or Plavix at discharge. And they have to go on a statin therapy, which means we would give them one of the many statins that are available to decrease their cholesterol level. And particularly, we're focusing on their LDL. We want their LDL in the lipid panel to be less than 70. If it's more than 70, which it is for most of our patients, they have to go home on statin therapy. So those are the two meds they need at discharge. The only thing to compare it to is you looked at your hemorrhagic stroke patient, they have a few less measures to be met, not as many as ischemic stroke, but here they have to have the VT prophylaxis, the stroke education, and they have to be assessed for rehab. In the Get With the Guidelines stroke core measures, which is the program that American Heart runs, we can also pick some additional measures that we want to follow, and it's good for patient safety, and it's good for patient outcomes. And that is what we call the NIH score. We follow that to see how many times our staff documents the NIH, because it's a good way for us to check neurological status. It's a great neurological assessment. We do a modified Rankin score, which is a specific score that therapy rehab therapists do, and that will tell us our patient's function level. And then for our patients that are smokers, we make sure we teach on smoking cessation. So we picked those three measures, the NIH, the modified Rankin, and smoking cessation, because we wanted to make sure we went above and beyond to follow other measures to give our patients the best possible care. So we do this every day. We are abstracting charts, we're teaching patients, we're doing these measures, and on a monthly basis, we pull the data to see how we did. Then we say VTE enlightenment. This is something that when we're teaching the patient about that one measure, are our patients allowed to refuse it? Well, the answer we say, of course they are. Our patients are allowed to refuse any treatment, but we would just have to document it. So that's one of the acceptable reasons if the patient maybe didn't want to put those boots on that I was talking about because they said that it was annoying them or it bothered them. They can refuse it, but we have a responsibility to educate them and say, why do you want to refuse it? We need you to do this for this reason. That's to prevent clots. Maybe they're just refusing because they don't understand. So we do try to educate and enlighten them on that. Then if we go on to our other stroke core measures, we do swallow screens. We make sure we teach the patient the importance of doing a swallow screen, and we make sure that we give them a certain amount of fluid to drink to see that they can safely swallow before we give them any oral intake, right? No water, no drinks, no food, no medications until they drink the 3 ounces of water, and we check them safely, and then we pass them. If they fail, well, then we have to call in a specialist, which would be our speech therapist. But these are nurses that are doing the bedside swallow screen, checking the patient for safe swallowing. And we do all of that as part of our stroke education and educate them as to why they do that. When we're educating them, we are also teaching the patients how to recognize stroke, and we use BFAST. So BFAST is balance. Does the patient have a loss of balance? Eyes. Does the patient have a sudden change in vision or trouble seeing? Is it the vision blurry? Is there double vision? Does the patient or person have a facial droop, like one side of their face is drooping? Ask the person or patient to raise their arms up in the air. If they raise them both up in the air and one drifts down, we have one-sided weakness, then that is a stroke symptom. Speech, we ask them to speak, repeat a simple speech. Is their speech slurred, or are they just having trouble getting the words out? That's another stroke deficit. And then we have T for time. We want to move quickly, right? Because we said we are just trying to go as quickly as possible in the hospital. And if they're home, it's calling 911. Then we have other stroke core measures, right? So these are the only ones that have to be done at discharge. I told you the ones that have to be done at the beginning before they go home. We have a checklist and we make sure, did rehab see the patient? Yes. Did we teach smoking? Yes. Did we discharge them on an antithrombotic? Yes, an aspirin. Did we discharge all patients with AFib on anticoagulation? Yes. And are we discharging them on a statin? We need to check yes for all of those, or the doc has to write why not. So the swallow screen. Let's talk about the swallow screen. What's the big deal? The big deal is if the patients can't swallow correctly, if the patients can't swallow safely, there is a risk of aspiration. And with aspiration, their patients can get pneumonia. It could be a silent aspiration pneumonia even because of just the way they swallowed and it went, the saliva even went into their lungs. And we know this fact. Pneumonia causes the highest mortality of all medical complications. So we make sure we do that. So what do? We ask the patient to drink 3 ounces of water. After they drink the 3 ounces of water uninterrupted, they drink it down in one gulp. And we ask them to cough and they have a clear cough. There's no rattled cough. There's no wetness. There's no choking. Then we say that's good. They pass our swallow screen. If there's any reason that when they're doing the swallow screen, they stop during it, or they have a wet rattle or gurgle, then we fail them. This is a evidence-based tool. So because it's evidence-based, it's not something we made up. It's something that's been tried and proven that this comes up accurately in telling us if the patient can pass. Sometimes when they come in, if they're not very alert, we don't want to give them a drink of water as soon as they come in. So we might wait an hour or two until they are alert enough to be able to do the screen. If it's not true and they can never happen and they can't pass it because of the choking or because of the gurgling, any concerns, we will fail them and we stop everything. No oral intake, and we call in the expert, the speech therapist, to do the evaluation. Some tips we give our nurses is we will say to them, you can use a cup or a straw. The patient doesn't have to be able to feed themselves. You can help them. You can hold the cup and have them drink the 3 ounces with a straw. Then we have some nursing focuses that we like to focus on throughout the whole hospital stay, and things that are always on our radar. We want to make sure that our patients are always evaluated for different kind of reperfusion therapies. So can we get the blood vessel open to let it flow again? Do we give thrombolytic therapy, which means we give one of our medications, the tenecteplase or the alteplase, to open the clot and open the vessel? Or is the clot so big that we're concerned and we want to get that clot out of their brain? We're a primary stroke center, so we don't do interventions like that here. It's a higher level of neurointervention. So we would transfer the patient out to another hospital. And they would be called a comprehensive stroke center. And at that hospital, they have the ability to be able to go into the brain through usually the groin or the radial artery. And they use a catheter, they thread in, they will pull the clot out. So it's either going to be a mechanical intervention or a pharmacological intervention. The thrombolytic therapy would be our pharmacological intervention, and the mechanical is the thrombectomy itself with the catheter. Then we also focus on secondary prevention. What got them here? How can we prevent it again? Like the high blood pressure, the diabetes, and the cholesterol. What can we do about those risk factors? And what is our highest level of rehab that we can get that patient to so they can get back to their best self, so they can get back to their baseline? Things we also worry about in the hospital, things that core measures that will maybe let us know how well a patient is going to do. A recommendation, we call it FES, fever, sugar, swallowing. So look at their fever. If they have a high temperature, that can be a bad outcome. Report that to the physician. Sugar, we always check glucose levels. If their glucose is high, greater than 180, that could be a indication of poor outcomes. Always work with the physicians or the providers on controlling blood sugar. And then we already talked about swallowing, that we want to make sure we're working closely with our speech therapist for anybody that would fail a swallow screen. This is a checklist that we provide to all of our nurses on the units just to remind them, because there is a lot of core measures. As you can see, we've been discussing how many there are. And it's not the only thing a nurse is doing on a unit. They're taking care of many different patients with many different diagnoses. So we give them this guideline and we have it posted on the units, and the nurses also have an area where they can pull out educational material to help them remember what to do. So this will remind them of everything that we just discussed. VT prophylaxis has to be initiated and documented in the first 24 hours. We give them the two different choices of what are the two areas or the two different prophylaxis they should be using, mechanical or mechanical or pharmacologic, and it should be done in the first 24 hours. So they're timed. When should they do it? The same thing with the early antithrombotic, right? The aspirin or the Plavix has to be given within the first 24 hours. And if they can't swallow, instead of giving an aspirin oral, you give it as a suppository. They know they have to meet that measure. The next measure they have to meet is the swallow screen. If they fail, they're going to reach out to speech. The next one is lab work. So we want to always know what a person's lipid panel is and their A1C, because we're monitoring their cholesterol level and we are monitoring their A1C for sugar, for diabetes. Patient education is done a little bit every day while they're here, every shift, so that we're building on that education so that they have good knowledge of what to do before they go home. PT and OT does have to see them within the first 24 hours and again at discharge. And then we talked about the meds at discharge are your antithrombotics, your anticoagulation, and your statins. And this is a great tool for the nurses to use so that it's a reminder for them, this is how we give the best evidence care, the best care for our patients so that they can have the best outcomes. And we do this all together as a team. We help each other and we make sure if we can't get something done in one shift, we pass it off to the next shift, say, I got this part done, can you carry on for me? And we all help each other meet these measures for the best care for our patients before they go home. And I know it's a lot, but stroke is very involved and we take it very seriously. So that's just some suggestions of how we do it here. And thank you for listening. And if you have any more questions, I'm sure you'll be able to find Jessica. She can help you just go over some of her references here that she has at the end of where she looked up some of the evidence-based practice that we do here at our hospital. So thank you very much and have a great day.
Yeah, thank you, Teresa. That's a wonderful lecture. Thanks, Cece, and all of you for giving us this opportunity to share. I wish the best to you all. Bye.
Bye-bye now. Thank you.